Good evening
Yeah,
to all the aspirants present here. The topic for today is cardiology, and the faculty that we have here is Dr. Manidipa ma'am. She is a well-known doctor. Ma'am, you can start. Thank you.
yeah, sure. So this is the fourth session and likely the final session of the cardiology part of MRCP. Of course, as you understand, not everything, every detail and every disease of the cardiology we can revise before the exams. So I have tried to include all the sections, major things that come in MRCP part 1 and part 2 in all the last four sessions that we have studied in. If anything, any other queries or major doubts are left, maybe we will request the coordinator to arrange a question and answer or doubt clearing session for maybe all the subjects or subspecialties. In that we can discuss more on cardiology. So this last session we are going to talk about conduction abnormalities and diseases of vessels, means arterial and venous diseases. Today's objective: conduction system brief overview, brady and tachyarrhythmias, AF, atrial fibrillation and management, syncope and pacemakers, peripheral vascular disease and limb ischemia, DVT, and pulmonary thromboembolism. So, conduction system of heart, as you all know, we have structurally there is the SA node, the sinoatrial node, the atrioventricular node, the AV node, then the bundle of His, then right and left bundle branches, and Purkinje fibers. So, SA node we had read in cardiac anatomy, the first class, that it lies in the right atrium at the junction in the epicardial surface at the junction where the SVC, superior vena cava, is joining the right atrium. It is the primary pacemaker of the heart and has an intrinsic rate of 60 to 100 beats per minute. Mostly in most of normal human beings, it's between 70 to 80 the heart rates are. So cardiac conduction system tissues differ from normal muscle fiber in sense that they have automaticity, conductivity, excitability, refractoriness, and coordinated atrial then ventricular contraction to maintain a proper cardiac cycle. If both atria and ventricle contracts together, then there won't be any proper cardiac cycle and there will be an acute decrease in cardiac output. We will come to that, in which scenarios that kind of thing might happen. Can anyone guess in which scenario there can be simultaneous atrial and ventricular contraction? Can anybody answer? Has any idea? If you remember during the class, please let me know in the chat box. So here, to just remind you, from the sinoatrial node, the impulses go through the mainly through the atrium into the atrioventricular node. These are the three bundles: the anterior, posterior, middle internodal bundle, which lies mostly in the right atrium. And SA node is also in the right atrium only at the junction of SVC and the right atrium. And from the right atrium to the left atrium, the excitement, the action potential goes through fibers called the Bachmann's bundle. Okay, so this is the left atrium. From the atrioventricular node, it's a long elongated structure which has suprahesian, hesian, and infrahesian part and goes to the bundle of His. From this bundle of His, we have the Purkinje fibers coming down, the bundle branches firstly. On the left side, there will be left bundle branch which divides into left anterior fascicle and left posterior fascicle, and there is the right bundle branch on the right side, which is the smaller and thinner one. The left bundle branch is larger and thicker, and this bundle branches give rise to the Purkinje fibers, which depolarizes the ventricles from an endocardial to epicardial. The activation is from endocardium to epicardium. So these are the other structures near AV bundle. What are the other pathways? These are, I have just put here because very rarely it might come in MCQ in part 1, but very unlikely. What are the names of the accessory pathways? So bundle of Kent, you can see it's across the tricuspid annulus, This is the accessory AV node present in most of the people, absent in a minority of population. This is the AV node. Atriofascicular bundles are mostly this one, the Mahem fibers. The Mahem fibers are famous to cause different kinds of re-entry tachycardia. Okay. So next we are coming to how the action potential looks in different parts of the heart. So SA node, the action potential looks somewhat like this. So phase 0, 3 and 4. Why is the 4 like this? There is never an isoelectric baseline voltage in sinoatrial node, because stage 4 also we can see slow depolarization in the phase 4 in sinoatrial node. There is slow depolarization in AV node as well. This is very prominent in excitable tissue or excitable cells or pacemaker cells, which is caused mainly by two important current. This one, IK1 and IF. IF are funny currents, right? So this is K1, one potassium current invert, and IF, that is funny current. So these two are responsible for the phase 4 depolarization in pacemaker cells. This might come as an MCQ. This is the typical, on the right hand side, we can see this is the typical action potential in a cardiac myocyte, which is true for Purkinje fibers as well as any other cardiac myocytes, which shows a plateau. A plateau is important because the plateau phase, this is the phase where the main contraction happens. If the action potential were like a nerve cell, which is just a sharp upstroke and sharp downstroke, or like a pacemaker cell, which is relatively again narrower compared to a myocardial cell, then there won't be adequate time for the contraction. So this delay is called the plateau phase, which is mainly maintained by the inward calcium movement. Please go through the physiology. We do not have enough time to go through in detail, but this cycles and the type of currents, what current is seen in phase 0, phase 1, phase 2, phase 3, phase 4, all these are important questions that may be asked. So coming to bradyarrhythmia, these are the major types of bradyarrhythmia: sinus bradycardia, sixth sinus syndrome, atrioventricular blocks, junctional rhythm, and ventricular escape rhythm. So causes of bradycardia, this is mostly sinus bradycardia, physiologically in athletes, but which stays between 50 to 60, less than 50 is rare. Intrinsic cardiac causes can be idiopathic degeneration, which is the commonest cause. Idiopathic degeneration and infarction and ischemia are the commonest cause. Degeneration can happen in form of fibrosis or fat deposition or sclerosis and non-functioning of the pacemaker cells. Infarction and ischemia, as you can understand, it happens in myocardial infarctions or chronic coronary artery diseases. Other causes are myotonic dystrophy, which affects the heart muscles as well. Congenital heart disease, in which there is developmental defect in formation of the conduction system, either at the SA node, AV node, or the intranodal tract areas. Then there is sixth sinus syndrome, which is again common in older people. Infections like endocarditis, myocarditis as well, actually. Drugs, we are coming to that next. Autonomic mediated situational vasovagal syncopes, vagal stimulation will definitely cause this one bradycardia that affects the pacemaker cell as well as the conduction. So it's a negative chronotropic and negative dromotropic activity of vagus. So situational causes of bradycardia will involve a vagal stimulation, carotid sinus hypersensitivity, cough or micturition syncope, systemic illnesses like hypothyroidism or hypothermia, sarcoidosis and amyloidosis, which again causes infiltration of the cardiac myocardium and interferes with the conduction pathway. Head injury like in Cushing's response. What is the complete Cushing's response? Bradycardia and what is the other part? What is the other component of Cushing response? Okay, we'll come to this next. So, hyperkalemia, electrolyte disturbances like hyperkalemia and hypokalemia more commonly caused, bradycardia is more commonly caused by hyperkalemia. Drugs causing bradycardia are AV blocking agents like beta blockers, CCBs, digoxins, cholinergic agents like organophosphates, antihypertensive agents like clonidine, antiarrhythmics like quinidine, and antipsychotic agents such as lithium or